My name is Edward Pena. I'm a part of Group 1, and we're here to talk a little bit about the model Occupational Adaptation. Within the occupational therapy domain, there's a variety of models that have been placed with supporting research and evidence-based practice to shape the way clinicians go about the clinical process. From initial assessments to intervention to reassessing and providing possible outcomes, all of these models begin from a theory developed by a person or a group of people overseeing and collecting data to form a hypothesis or a testable prediction. If the result of the hypothesis were consistent enough, it would then become a theory. According to Ravi Jajjani in 2019, a theory is a way to interpret and explain one or more phenomena that may carry many different variables, structures, processes, functions, or principles. All of these many types of variables would need to be tested to be used in an evidence-based practice. The result of these theories that become evidence-based practices is why a theory is important to us in occupational therapy. One of the models we are speaking on today is the Occupational Adaptation model, which name basically describes the basis of what it means. In the middle of our Venn diagram, we have placed the definition of occupational adaptation in our own words, which is creating new processes in response to challenges during meaningful occupational activity. Pretty straightforward. I'll give you an example. Working pediatrics, some goals are based around shoe tying. Naturally, we will begin with the conventional way of tying shoes. If the conventional way of tying shoes is not having success, we start to adapt the activity by switching methods or even introducing adaptive tools to assure our patient meets their goals. So I want to kind of show what I mean by that. In shoe tying, conventional way will be 2 laces, cross, tuck one under, 2 bunny ears, cross, tuck one under, and pull, right? But if our patient's having fine motor difficulties or any other difficulties that may refrain from them being able to do that, we can do 2 laces, cross, tuck one under, 1 bunny ear, loop around. The loop around kind of makes like a little bridge, and then you kind of just pull the loop through and it ties there. So adapting the activity to meet our patient's needs. That's it from me. I will pass it over to Mike, and thank you for your time.
Thanks, Ed. Today I'm going to be focusing on questions 3 and 4. Our model is the occupational adaptation. And at the center of our Venn diagram, as shown, we have came up with creating new processes in response to challenges during meaningful and occupational activities. So let's review the diagram. As you can see, our 3 most important main concepts of theory in the Venn diagram are 1, our person concept, 2, occupational participation concept, and 3, the press for mastery concept. So let's go ahead and define each concept and apply its value to our Venn diagram. The first, person concept. Person concept is recognizing a challenge within and desiring to master your environment. This we perform in a 3-person system. 1 cognitive, 2 sensory motor, and 3 requiring psychosocial skills. The second concept would be occupational participation. This is our innermost process to manifest change. This leads to increased adaptation, which leads to increased occupational participation. Now, occupations have 3 important properties. They require active energy, they serve a purpose, and they are goal-oriented. Lastly, we have the press for mastery concept. When a person in an occupational environment transact during occupational participation, the press for mastery manifests. This is done in 4 processes, or occupational roles. Now, the first one is your person. It's your defined set of behaviors and what is acceptable. The second is occupational challenges or your capabilities, where you start from. The third is your role demands, and that could be internal and external. And lastly is your occupational response, what you do. So if you combine those 3, we feel that those 3 would get us the ability to create new processes in response to challenges during meaningful occupational activities. Now let's hear from Priscilla.
Thank you, Mike. Hi, everyone. My name is Priscilla, and I'll be covering questions 5 and 6 on the Occupational Adaptation Model. The Occupational Adaptation Model was created in 1992 by Janet Shakade and Sally Schultz at a Texas Woman University. They wanted to explain how people adapt through meaningful occupations when facing challenges. It's based in occupational therapy, but also draws from psychology, human development, and system theories. This shows adaptation is not just physical, but also cognitive, emotional, and social. Over time, the OT leaders like Carolyn Bum and Charles Christensen added these ideas, helping OA become a key holistic model in our field. Now that we know who developed the model and where it comes from, let's look at how it applies to client functioning on functional disability continuum. This model also explains client functioning as a continuum. Function means being able to adapt successfully and feel competent. Dysfunction happens when adaptive response don't meet demands. For example, someone with a stroke, depression, autism, or arthritis may struggle to adapt. What matters is that OA doesn't just focus on fixing the skills, it focuses on building adaptive capacity so people can still engage in the occupations that they're most meaningful to them. In short, OA reminds us that therapy is about supporting adaptation so clients can live fulfilling, meaningful lives. Next is Tyra to present questions 7 and 8.
Thank you, Priscilla. My name is Tyra, and I'll be covering questions 7 and 8. Change occurs for clients through a process driven by occupational challenges, how a person responds to adaptation, environmental influences, and when a person reports improved mastery. Personal and environmental factors can influence the client's occupational performance in a positive manner. If that occupation is meaningful to the client, then that client will do everything in their power to engage in that occupation and will adapt so that they can be as independent as possible in their desired occupations. Some environmental factors that can also positively influence a client are physical, cultural, and social. Receiving positive feedback from family, friends, and peers can positively reinforce their need to continue to use their adaptive skills so that they can facilitate independence. Adapting the physical environment to make it easily accessible, whether it's products or technology, can also push that client into the positive direction. To learn about a client's functioning using the OA model, you can observe, look at the occupational profile, and ask questions. For example, here are some questions that you can ask. What are the roles you have in life? Are you a parent, student, worker? What occupations or activities are most meaningful to you? And have you ever experienced a time where you had to adapt or adjust to continue to do something that is important to you? Some ways you can observe occupational performance will be by direct observations, tools and assessments, analysis of tasks, and self-report from the client. Some assessment tools that are available to help with this theory will be the Canadian Occupational Performance Measure, which is designed to identify a client's perceived performance and self-care and leisure tasks, and the Modified Barthel Index can test the client's ability to perform daily living activities and their overall mobility, just to name a couple. Thank you so much. I'm going to pass it to Diana now.
Thanks, Tiara. Occupational adaptation model is different from other approach because it doesn't just teach one skill at a time. Instead, create real-life situations where clients can try things, reflect on what worked, and then adjust for the next time. In other words, therapy is about practicing adaptation while doing meaningful activities. There are a few key ideas. First, we look at the whole person, not just performance, but also what OA calls relative mastery, where the client feels effective, efficient, and satisfied. Second, therapy supports meaningful role life, like being a parent, student, or worker. Third, the client take the lead in occupation while the therapy support reflection. Also, in OA, occupations themselves are the main tool. Real activities like cooking, cleaning, or organizing are used for therapy. Finally, we always consider the environment since it can either support or limit performance. Research support OA in many ways. Clients show very progress when therapy focuses on meaningful roles instead isolated skills. They also grow in adaptive capacity when they learn to transfer strategies from one situation to another one. So OA is a strong client-centered model that helps people build confidence and adaptive skills to face life-changing demand. Thank you everyone for listening our presentation.